that I see a lot is religious beliefs, which is great for this audience. They belong to a religion that believes that suicide is a sin. Well, that's understandable if they believe to that religion, but you need to keep the conversation going on what they believe this means to them. I had one veteran who initially said that he believed that suicide was a sin. I talked to him about his beliefs on that issue, and he further said, well, I was a paramedic, I was an officer, a police officer, so I think that I could offset the sin of committing suicide. Because he saved all these lives in his job, he said he could offset the sin of committing suicide. So just because somebody says that they believe that it's a sin, you need to delve further a little bit more into what their belief system is and how it relates to suicide and their beliefs. He made a verbal or written promise. How many people out here use suicide contracts? Or no suicide contracts? Stop using them. They're not worth the paper that they're printed on. The only thing it does is it makes you feel better. It doesn't reduce suicide by any means. What it does is it just, you're just signing a piece of paper. And the problem is if, because the new standards of care have been changed. So if you use a new suicide contract and something happens and you end up in a lawsuit, you'd probably fail. Because the standards of care now is that we don't use no suicide contracts. What we do use as safety plans is that we work on a plan to keep the person safe. But there's no contract of what they will do or what we will do. It's things to do that to keep them safe. And again, I can give you my contact information, and if you need any of this information, suicide risk assessments, safety plans, things like that, I can send them to you. Again, the intent to die can override. That's not a rational act. If you put a lot of emphasis into these protective factors and just the belief without going through the vet and even talking with the vet and finding out what their beliefs is, you may end up losing the vet. And this is Operation Save. This program hopefully will allow you to further assess and help veterans. They use care and compassion, I use empathy and concern. It's the same thing. This acronym SAVES helps someone remember the important steps involved in suicide prevention. Again, know, learn, live, the signs of suicidal thinking. Ask the most important question, and we'll tell you how to ask the question. Asking the question is the most important part of assessing somebody who's suicidal. Validate the veteran's experience. Remember that the worst thing that ever happened to this veteran has happened. Doesn't mean it's the worst thing that's ever happened to you. It's the worst thing that's ever happened to this veteran. So validate their experience. And encourage treatment and expedite help. Again, many veterans might not show signs of intent to harm, but you need to look for the signs. Signs or behaviors that a veteran is thinking to do something. And a veteran in crisis might show behaviors that indicate risk. Again, if they're not, untreated depression raises your risk well 68 times higher than the normal population. Some of the signs of depression, especially with males, may be different than how they show up with females. Hopelessness, helplessness, feeling like there's no way out, feel like a burden, feel like there's no way out of the situation. They feel like they're trapped. They feel like there's nothing that they can do to get out of the situation. That they feel like they're in a corner, that whatever they do is wrong. They feel that there's no way I can get out of this situation. Anxiety, agitation, sleeplessness, mood swings. Males, when they show depression, will show anxiety and agitation. It's not tearfulness and other things. It's more aggressive, more agitated. So what you may think somebody may be a very difficult patient may be actually having some untreated depression. Feelings like there's no reason to live. Again, hopelessness, helplessness, a burden to family and friends. Rage or anger, again, could be incidents of untreated depression in males. Engaging in risky activities without thinking. This would be substance abuse, this would be risky behaviors. One of the things that we see a lot of with the returning veterans is the race bikes. You see them going in and out of traffic. There's been a lot of deaths from those, and it's hard to determine whether it's suicide or accident. Increasing alcohol or drug abuse. I've had people say that they drink a 12-pack of beer just up and go to sleep each night. And then withdrawing from family and friends, giving away possessions, growing quicker than small. The presence of any of the following requires immediate attention. Thinking, talking, actions that they want to kill themselves or somebody else. Looking for ways to die. Somebody coming in asking for a lot of medications, stockpiling medications. At the VA, we have the ability to restrict people to weekly meds. So we're only able, we say that we give them weekly meds, that they only get enough for 1 week. Some of the medications we give somebody is enough for just 3 days. What that does is it allows us to give the veteran enough medications to treat their illness, but it doesn't give them enough to overdose. Now everybody says, well, what if they're stockpiling their medications? Also, seeing them frequently allows us to assess their mental status. So again, if they're decompensating, not taking their medications, there are certain things you can see. Hygiene changes, mood changes, things like that. Again, so we're continually assessing them and lay eyes on them. Self-destructive risk-taking, again, alcohol, drugs, weapons, talking about death, dying, or suicide. Veteran-specific risks, frequent deployments. We've had veterans who've been deployed 5, 6 times. Very stressful situations. What differs than the World War II, Korea, and Vietnam vets is length of deployments and frequency of deployments. Deployments to hostile environments, exposures to extreme stress. Imagine yourself a car, we'll say a Ferrari. It's a highly tuned vehicle. However, if you keep that Ferrari revved at 9,000 RPMs, you're going to blow it up. So just imagine a person who's in an extremely stressed environment. Anxiety levels are pegged. What's going on with their sympathetic nervous system? Their heart rate is continually at a high rate. Hormones are being sent throughout their body. They're extremely at stress. High rate hormonal change, cardiac changes, revving really quick. Physical and sexual assault. This doesn't only mean females. It means males also. 1 in 72 males are a victim of MST, or military sexual trauma. So when you're talking military sexual trauma, you also need to talk to your males. Females, it's 1 in 8. So high rates of military sexual trauma. Length of deployments and service-related injuries. Imagine you're a 24, 25-year-old who just come back from a deployment with some sort of cognitive impairment, traumatic brain injury. You're not as quick as you used to be. You're not as active as you used to be. You're not able to do the things that you used to do. You have other physical limitations. You have cognitive limitations. You go to the VA and you see older veterans and you think, oh my God, is this going to be me 20 years from now? Again, you start feeling hopeless. You don't feel any hope in the future. Is this what my life is going to be? I used to be the smartest kid in my class, and now I can't even balance my checkbook because of traumatic brain injury. I used to be the big man on campus or big woman on campus, and you come back and you have some physical deformity with your face or your body. Again, these are things that our veterans are dealing with. I used to be really active. I used to be a runner, and they lost a limb. So just body changes, cognitive changes, mental health changes. And again, how to ask the most question of all. Why is this clicker not working? That's the most important question. Are you thinking about killing yourself? Not, oh, are you thinking about hurting yourself? You need to ask, are you thinking about killing yourself? Two different questions. But you need to ask it in a way that you're comfortable. You just don't say, hi, my name is David, are you thinking about killing yourself? You need to do it in a way that it's comfortable, that it flows with the conversation. That what you're doing is part of your assessment. You ask them, I'm thinking about suicide. One of the things that I say is, people who have had similar situations have thought about killing themselves. Is that something that you're thinking about right now? And again, you need to do this with empathy and concern. Again, you can't sit there and, look at your computer. What I try to tell people to do is sit next to the veteran. That way it's more of a collaborative approach, more of a collaborative assessment. Ask them, have you thought about taking your life? Have you thought about killing yourself? Have you thought about shooting yourself? Again, I'd ask people, have you thought about putting a bullet in your brain? Again, you find a way that's comfortable. Assess it. Again, find out a way that's comfortable for you. But again, assess the veteran. I mean, sometimes you need to talk in the language of the veteran. Earlier we were talking about cultural changes and cultural ideas. Again, some of the lingo you need to understand or be aware of. Sorry. Ask the question if you've identified the warning signs. And again, don't just blurt it out. Don't be talking about dogs and cats and saying, oh, by the way, are you thinking about killing yourself? But don't ask it in a way that you're looking for a no answer. It's 5:30 on a Friday. You're going to meet your friends for a happy hour. Somebody comes in and they're depressed. And you look at them and say, well, you're not really thinking about killing yourself, are you? The veteran's going to think, well, this person really doesn't want to hear the yes answer. That they're really not interested in what I have to say. They're just in a hurry to get out and they're looking for a no answer. And don't ask the question as they're walking out the door. Don't have your meeting with them and then say, as they're walking out the door, oh, by the way, do you feel like you're going to kill yourself? You want to ask it as you're going through your assessment. And again, ask it in a natural way. If you're a very clinical person, ask it in a very clinical way. If you're a very relaxed person, ask it in a very relaxed way. Make it seem like it's a natural flow for you. But then when you ask the question, you need to remain calm. You need not to not to react when you get an answer that you're not liking. You need to make good eye contact. You need to act with confidence. You don't argue with the patient. This is not when you get into the philosophical or religious discussions on suicide. This is the worst thing that has ever happened to this veteran, and you need to validate their experience. Whether you believe it's a sin or it's wrong or it's weakness or anything like that, that's your belief system, do not get into a conversation with this veteran. The veteran is going to think that they're being judged. They're thinking that their situation isn't important enough for your time. They're going to feel like, oh my God, this person just doesn't care right now. They're not really listening to me, they're judging me. And again, they've gone through all the stigma that they've gone through, that they've been taught, that you don't ask for help, that you don't ask for mental health help, because what it is just weakness or it will destroy my career or things like that. Use open body language. Limit the questions and let the veteran do most of the talk. Be supportive. Again, show empathy and concern. Let them know that they're there to help. But be honest. If you're not able to help them, get them to somebody who can. To say, listen, I'm not able to help you, but let me call crisis team, let me call the VA, let me call XYZ, let me call a family friend, let me call somebody who can help you, who can get you through this. And don't leave the veteran alone while you're doing this. Have somebody work with them. Because usually what happens if you leave the veteran alone, the veteran will just walk out the door. We've had that happen. Talk openly about suicide. Let the veteran express their feelings. Again, this is the worst thing that ever happened to this veteran. Let them tell you why they feel this way. Why they feel that the best answer that they have to this problem is to kill themselves. I've had one veteran say that it would be better off if he was dead, because then he would get 80% of his life insurance policy, which will pay off his house, which will make sure that his family doesn't have bills. Because that's the most important thing to him, that his family is secure and won't have bills. And he feels that this is the best way that he can help his family. Otherwise, he would just be a burden. Don't pass judgment. Again, recognize that this situation is the worst thing that ever happened to this veteran. It may not be the worst thing that ever happened to you, but just recognize that this is the worst thing that ever happened to the veteran. And reassure that help is available. And again, if you're not able to help them, get them to somebody who can. What should I do if I think somebody is suicidal? Again, don't keep it a secret. Get somebody to help you. Let somebody know that this person is at risk. It's like Chapman Kropnik said that he wished he could have done something else, got somebody else to help, let somebody else know that this person was at risk. Don't leave them alone. Try to get a person to seek immediate help. Go to nearest doctor, hospital, VA, call 911 or our crisis network out here. Reassure that help is available or call the hotline. The good thing about our hotline is it's in Canandaigua, New York. Do not ask me to spell it. Ours is different than most other hotlines because what happens with our hotline is it's centrally located. They have databases for all the VAs. So if you call from Phoenix, it goes to Canandaigua, but if the person is enrolled at Phoenix, they have all their history. So they have when they were last seen, what medications they're on, things like that. So they're able to help the veteran, or if they need to get a crisis team or police out there immediately, they have all that information and they can get the police. Most other crisis lines out here don't have that information. And again, they have emergency contact information. They have prior mental health, prior medical treatments, what medications, things that worked and things that don't work. I got a phone call from Scottsdale Police one time. They had a standoff situation with a veteran, and by looking at the chart, I found out that this veteran does really well talking to other veterans. So what I did is I told the police, get another veteran in there to talk to him. And what happened is those 2 veterans were able to bond, and it turned into a safe situation. So again, that's the good thing about our hotline. Safety, never negotiate with somebody who has a gun. I don't see anybody here with bulletproof vests on. Get yourself to safety. Make sure that you're safe. Never negotiate with anybody who has a weapon. If somebody has a weapon, you need to remove yourself as soon as possible. If they have taken pills, cut themselves, or done harm in any way, call 911 immediately. If you can, make sure somebody stays with the veteran, but if not, call 911 immediately. Or call the crisis line, and then press 1. Just so you know, do not call 272-TALK. It's a whole different sort of talk line. Our lead suicide prevention coordinator gave that number to a congressman. Yeah, it's not a good number to call. So please call 273. Mental health. The VA provides specialty inpatient and outpatient mental health. Our VA here in Phoenix has an inpatient unit. We are able to take voluntary patients. So if they're voluntary, we're able to take them. Because of the changes in Arizona and the Title 19 and the mental health laws and everything like that, we are currently working with the courts of Arizona, the Superior Court, so we can have the ability to take non-voluntary patients. So if somebody is petitioned or if somebody is through the court system, we'll be able to take them. Because currently, right now, there's not a lot of services out there for them. And we feel that we're the best ones who could be able to take care of them. Vet centers. There's 3 vet centers in the Phoenix area. One's on the west side, one's in Mesa, and the other's in Central Phoenix. Good thing about vet centers is that they're vets talking to other vets. A lot of them are combat vets. So a lot of them can understand what the veteran is going through. A lot of them are able to help them through the traumatic experiences of PTSD, things like that. It helps them understand, okay, you've been there, I've been there, let's talk about it. They were established right after the Vietnam War, just for that issue. Another good thing about vet centers is everything that they say there is pretty much confidential. We don't have, the VA doesn't have access to what is said at the vet centers. So if you have somebody who is, got some issues and they're afraid that they're going to lose their security clearance or things like that, we usually tell them to go over to the vet center so that way they won't be, fearful of losing some of their issues. Some of the services that they provide is if you have a vet who is going through some domestic issues, they can go there and get marital counseling. If there is a death, say by suicide or some other manner, the family can go to the vet center and get some counseling.